O'clock by my clock here. I'm sure that's the same for you all. I'm just going to introduce ourselves and then to give us a minute or two for a few more people to join us, because there are still people coming in. We've got many people registered today for this event, so thank you for that, and I hope you have a great day. My name's Keith Brown, and I'm the chair of the Lewisham Safeguarding Adults Board, and delighted to welcome you here today. We've got two wonderful speakers, both Karen and Imogen, who will be presenting a couple of SARs that we've had published recently and going through them and giving us some of the learning points. What we're hoping to do today is to video the whole event and to video the presentation so that we can make them available. So as a part of that process, we're going to keep people's cameras off on the screen and also their microphones. So we'd be really grateful if you would like to raise any points, raise any questions or any thoughts in the chat box. We'll try and look at those and collate those as we go through the day, through the event, and then we've got plenty of time at the end to take questions that have come up through the chat box, and we'll try and manage that and get through the material that way. I don't want to start just yet. I just want to wait another minute just to make sure that anybody else who's trying to get in can get in before we start. So we'll just have a few more minutes, seconds or so before we crack on. But I hope that is what you're expecting today. And I'm certain it's going to be a very informative and really helpful and productive morning and afternoon for us. So thank you. We will finish in time by 2 o'clock. Okay, so I think we'll get going. As I mentioned earlier, we're going to keep people's cameras and microphones off, so please ask any questions or make any comments in the chat box. We'd also be particularly interested if you'd like to share with us any reflections or any thoughts about today's proceedings and what you've learned. And in particular, we'd be interested to know whether there's any learning from these events that you might be able to take forward into your own practice, to either change practice, inform practice, how we think we might have an impact through a learning event like this. So without further ado, I'd like to introduce you to Karen Rees, who's going to be presenting today her material and her reflections from her report. I've known Karen a while. It will be a tremendous event, I'm sure, and she's going to take us through. So Karen, over to you, and thank you very much for coming to be with us today.
Thank you, Keith. Welcome, everyone. I just want to make sure that my slides are sharing. So just bear with me until I get to the beginning of my slideshow, and hopefully the technology all works well. And please, could somebody put in the chat box if I disappear, because my Wi-Fi connection in the mountains here in Crete is sometimes not the best, and we've had some pretty rough weather recently, but today's all sunny, so hopefully it doesn't affect the Wi-Fi too much.
That's all working great from my end, Karen, so I'm hoping it's the same for everybody else.
Thank you, Keith, for letting me know. So I undertook an adult review regarding Maria. And first and foremost, I just want to go through some of the process that we went through, because I think it's really important to understand not only what we learned and what we found out, but actually how did we get to that learning? Because I think sometimes in practice, unless you are working directly with a Safeguarding Adult Board, you're in a Safeguarding Adult role, you often actually don't come across being involved with a Safeguarding Adult review. And I know throughout my nursing career, I only got involved in reviews once I was in a safeguarding role. So what we did, we prepared some pre-learning event documents from an agency, Chronology, and reports, and we all met together. So that was the people that were involved with Maria met together on the 11th of June. So that's quite a while ago now. That's 11th of June last year. And from that, I was able to hear directly from those frontline practitioners what it was like to work with Maria and the environment that she was living in, but also what professionals found helpful about working in a multi-agency environment. We then had a virtual workshop following up in August, and at that point we had a panel, a safeguarding adult panel, who became the consultation then and key leads for further research, so any outstanding questions I had. And then we go through various iterations of the report until we get to what is the final report, which is actually version 8 in this case, and that's the version that's been published on the Safeguarding Board website. So when I met with the professionals, we undertook thematic discussion. So we looked at Maria's history. And I think as I go through this presentation, you'll realise that it's really important to understand a person's history. What makes the person they are, the person that they are, and the person that you're working with today? They didn't just arrive in your service, they have a whole life behind them. We decided to look particularly at Maria's physical and mental health because she had some significant mental and physical health problems. She was a victim of domestic abuse, so we had conversations around domestic abuse. She was also alcohol dependent and also used other substances, although to be fair, in the time frame of the review, we did focus mostly on her alcohol. She was rough sleeping, but did have a property. So she chose to rough sleep. And I say chose in inverted commas, really, because I would suggest that it's not a choice she made easily. But those that have read the review will understand why she made those choices, and we can discuss those. And also we discussed, obviously, given it was a safeguarding adult review, we discussed how professionals used the safeguarding pathway, Lewisham Safeguarding Pathway. So I wanted to use a learning framework that looked at an appreciative inquiry type approach. So throughout the review, I was asking professionals and asking organisations, in this particular circumstance, so whatever it was we were talking about at the time, what is it that we want to happen? And also what's currently going really well. So you'll see in the report, if you've read it, and hopefully you'll get the chance to read it afterwards if you haven't already read it, that we've tried to focus on, what's going really well. And we know that professionals that were working with Maria knew her really well. There was a lot of professionals that had worked with her for a long time, and so therefore they did have that relationship. So we were able to discover what worked well. We were also able to think about what would work well in the future. So the dream element of those 5 Ds that I've recorded there. And then the work of the board afterwards and with the recommendations of the review is, so what do we need to do to make a difference? If we want to dream about something happening, what do we need to do to make that happen? Then we need to take action, and all of the follow-up work from the board with the action plan is to look at how do we know that we've actually made a difference. And part of that is trying to embed this learning with yourselves who may not have ever come across Maria, or even anyone who lives a life like Maria lived. Or you may have many Marias on your caseload. So what do we need to do to make a difference, and how will we know when we've achieved it? The professionals that I worked with felt that it was a very positive experience being in the workshop. And from that point, and what's always interesting to me doing these workshops is that people go away having built networks, built partnerships by being face to face with people they wouldn't normally come face to face with, and starting actions for themselves already. And that always really interests me. And, and it's one of the reasons I like to have those face to face workshops. In a safeguarding adult review, we always meet with the family. And in Maria's case, we met with two of her siblings. I met Vicky, who's let you into the room today and does an awful lot of work in the background with safeguarding adult reviews, met with me and the family face to face. And we heard about Maria's history. We heard about the family and how they functioned as a blended family. And we also met with them after we'd finished the review to talk about the findings of the review, and they are quite happy with the safeguarding adult review. So that was all a very smooth process, but very informative, particularly to me as the author when I'm trying to write about a person. And this is the person that was Maria. So what we know is that she was 54 years old. I've used her photograph. The family are quite happy for us to use the photograph of Maria. And I think it's really important that we're able to put a name to the face. And that's why Maria's photograph is also on the front of the published Safeguarding Adult Review. Unfortunately, Maria had a long-standing history of alcohol abuse. She was a victim of domestic abuse. She had an extremely traumatic childhood that continued into her adult life. She has two children that were adults, but she didn't have any contact with them. She had two brothers and two sisters. Her younger brother was murdered in October 2022, and that had a significant impact on Maria. Engagement from agencies was problematic. So when we're talking about engagement, it's not the person that needs to engage with agencies. It's agencies that need to find the most appropriate way to engage with a person. So it's the engagement from the agencies that was problematic. And unfortunately, Maria died from alcohol-related physical health issues in June 2023. Unfortunately for the family, particularly, the coroner's inquest is still outstanding. So they are still waiting for the final inquest, which, as you can imagine, is very difficult for families. So what did we find? So in thinking about history and understanding the person and trauma, we know that good trauma-informed care starts with building good relationships, and that's why I say that there was evidence of quite a lot of that. If you use good trauma-informed care, it supports victims to engage with services, so it makes it easier for services to be able to engage with victims if they understand that trauma. We know that if services are flexible, they offer better options to victims of trauma. So, thinking about whether your service only offers services and appointments from a clinic-based setting or from a building. And sometimes the buildings that you're in and you're offering people services to may also be offering services to people that have already got a significant history with the person. So in some reviews I do, people don't necessarily want to go to their substance misuse appointment because they know that their dealer might well be hanging around outside. So it's really important that we think about that flexibility. Trauma-informed care requires commissioners and providers to consider the best how to resource services and how to be flexible, because obviously it is often the commissioners that will dictate how a service is provided. There is flexibility within the service usually, and in this particular case what we found was that there were two services commissioned to deliver substance misuse services, one for the acute phase and one for maintenance and recovery services. And that was not helpful to Maria because she didn't have a good relationship with the secondary service. And also we need to have that strong understanding of the impact of trauma on a person if we're going to be able to offer those services and protections. In the physical and mental health impact on Maria, we know that Maria had several physical health conditions that affected her mobility, affected how she felt day to day, and also she had mental health issues. She was diagnosed with emotionally unstable personality disorder. And if you're not able to understand those conditions, then you're not going to be able to deliver a service that is right for them. So, you know, those health conditions are really important to understand, whether they're physical or mental health. And also consideration of those health conditions can impact the mind of brain, which means that you are already on the first step in recognition that you should be using the Mental Capacity Act and any legal powers that may be required. And the report goes into the detail of that, particularly around executive functioning, which many of you may have heard about. Having a health action plan could have meant that all people could understand the impact of the physical and mental health issues that Maria had, rather than her having to tell her story over and over again, or indeed with people working without a knowledge and understanding of those physical and mental health conditions. And what we found in this case, that the GP was undertaking MDT meetings for those of their patients that had considerable vulnerabilities and where there were safeguarding concerns. Those multidisciplinary team meetings are actually a really good way of helping to deliver that multi-agency approach where there are health additions and offering that team around the person approach. Unfortunately, in this case, Maria was discharged from those vulnerability MDT meetings because she wasn't engaging with the GP. So there's quite a bit of learning there about, you know, how we might avoid that. And actually at the time they're not engaging, maybe it's the point is that actually we should be trying to engage more and not discharging. And some of you will think about cases that you've closed or you've been asked to close because of non-engagement of the person. When we come to alcohol dependency and polysubstance misuse, what we see is that if we use the evidence-based practice, and there's a lot of information out there on how best to work with people who are alcohol dependent, who are particularly vulnerable, and who have got multiple issues, including homelessness or street living. Maria wasn't technically homeless because she did have tenancies. When we see people with alcohol dependency admitted to hospital, as Maria was quite often, she would then be obviously detoxed while she was in hospital. When she was back discharged to her own property, although she didn't go there, she would very soon start with drinking again. So thinking about that in-reach to hospital and joint working between hospital and community substance misuse can support that trauma-informed approach. And also what we need to do is make sure that we're embedding learning from safeguarding adult reviews, because what we will often see is a similar theme running through safeguarding adult reviews. And obviously that's why Lewisham spend a lot of time and effort trying to make sure that everyone's aware of the learning from safeguarding adult reviews. If you're working with someone who's rough sleeping, then housing outreach support can be really valuable to tenants. And in this case, some of the teams that Maria worked with who were on the housing sector, she had really good relationships with, but then there can be blocks and barriers to housing solutions. So Maria would be offered a hostel where there'd be quite a lot of people who would be a risk factor for Maria. So she always refused to go to a hostel. What she really needed was a full needs assessment to support effective housing solutions for her that were person-centred. And if she didn't engage in her section 9, so social care, wider assessments, then we can use section 11. So we can look at the needs of a person without their consent, using section 11 of the Care Act. And also the one gap in that multidisciplinary team meeting that was at the GP practice was housing representatives. So if they'd have been there, that would have been really positive, because they'd have seen how some of the physical and mental health conditions that Maria had might impact on her housing needs. So she had mobility problems, but her housing was on a first floor flat with outside concrete steps and not an internal lift system. The safeguarding pathway, then, we need to think about that. There was a MARAC undertaken for some of the domestic abuse that Maria disclosed. And it wasn't as effective as it could be, because the MARAC and the safeguarding section 42 didn't really marry up. So what the MARAC was indicating from an actions perspective is what the safeguarding inquiries had already recommended, and that people had failed to get Maria to engage with. So there was things being advised in one section of multi-agency working that weren't congruent with what had already been tried elsewhere. But we know, from this safeguarding adult review, that actually there is a much better system now, and that there are social workers that attend, a social worker that attends the MARAC and has got a responsibility for domestic abuse as a social worker. We need to think about policies triggering automatic referrals. So again, there was a couple of police attendances where a MARAC wasn't considered and wasn't triggered. So systems that trigger that can help. And if we do use the safeguarding pathway, then it does provide a good response to when safeguarding concerns are being raised. We just need to make sure that we use it, and also that we use escalation and escalation protocols and pathways if we're concerned that the concern that's been raised hasn't been addressed appropriately. It's also really important that if you're recording any response to a safeguarding concern, that the rationale for decision making is also recorded, so that later on, when someone's looking back on your practice, and this is for any assessment really, that you have written why you made the decision you made, particularly if you think that it's been a difficult decision. But also it's important to remember that if you raise a safeguarding concern, you are not handing over your concern to someone else. You are raising a concern, and then you will be an important part of the ongoing safeguarding process. And again, use of escalation to ensure that you are able to understand what's happened as a result of you making or raising your safeguarding concerns. Wicked issues. Now, we've used wicked issues in academia and academic terms for a long time, but I think for the first time, I considered that when you have a complex person who has multiple issues, and we have to use a multi-agency response, because if a complex wicked issue, and this is all described in the report, what we mean is that it's not like manufacturing a Jaguar car, that you put metal in at one end and a car comes out of the other. You know, people are complex. They have complex lives. They have complex situations that they live in. And therefore, we have to develop multi-agency responses where we can use all of our specialisms and all of our innovative ideas to make things better for the person. So complex cases require multi-agency management oversight, so so that frontline practitioners aren't left to deal with these complex circumstances. And also sometimes you need to seek legal advice, so therefore we use complex risk management frameworks, and Lewisham does have one of these, and so do several of the other London boroughs, can provide that collaborative approach to wicked complex issues where one agency is really unlikely to be able to provide that support, effective support and solutions. So I'm not going to go through all of these recommendations. They're in the slide deck for you to look at later. They're in the report, but I just want to point out a few things. So there is a really good self-neglect policy in Lewisham, and I'm sure all London boroughs have a self-neglect policy. So it's important to understand what's in the self-neglect policy and how you can use it. And know that there are probably going to be updates to that self-neglect policy. There is also a 7-minute briefing which talks about and has links to the self-neglect policy as a result of Maria's life and her death, unfortunately. And also, it's really important that we think about how we engage next of kin and family to find out information, and how we can use those people that know the person the best. And also, it's really important to understand what your own agency's non-engagement and defaulted appointments policies are, so that we don't close those high-risk cases without thorough risk assessment. There have been recommendations made about understanding the trauma-informed person. There's been recommendations for commissioners about the commissioning of services, particularly around substance misuse, and also looking at the efficacy of MARAC and making sure that when a MARAC is happening, that it has got all of the information from previous engagement and processes and assessments that have been undertaken as they are relevant to domestic abuse. There's also quite a few recommendations about the safeguarding pathway, using audit to understand how well we're doing with safeguarding pathways, and also just some assurance seeking, really, that the adult gateway and the MASH teams know that there are multiple referrals. So one referral of a very, very significant serious incident could trigger a section 42. But actually, if you get lots of lower level concerns being raised all of the time, then that can have a massive impact on the person who is at risk of abuse and harm. So triggering an escalated response where there's been multiple referrals, we need those teams to be able to see that there has been multiple triggers. We need to still waiting for revisions to the Care Act section 42, but also thinking about the criteria of reasonable cause to suspect is also a trigger for a section 42 safeguarding inquiry, as opposed to a Care Act section 9 assessment. And we also have asked for revisions to internal processes to make sure that that section 11, where you can do an assessment without consent, is made use of. And also there was a fairly recent updated interagency escalation policy, and what we've asked is that the board are able to identify how effective that has been. There's recommendations made around mental capacity, about those GPMDT meetings and about embedding learning, which is why we're all here today. So that's really good to see. Also, there is a general learning briefing, as I've already mentioned, and we'd highlighted things that we wanted in that general learning briefing. So I don't know whether I've got time to show this, so I'm going to come back to this, but it is in the slide deck if you want to access this yourself. And if I've got time at the end of my presentation, then I will come back to show this very short video. So what can you do as a result of Maria's death? And one of the things that Maria's family were really clear about is that they wanted Maria's death and this safeguarding adult review to make a difference to people like Maria in the future. And they said that that would really comfort them if they thought that Maria's death had made some difference. So what we're asking you to do is discuss the things that you hear today and also disseminate to those that haven't been able to make it today. So if we're thinking about adopting trauma-informed approaches, we need to understand trauma, the impact of trauma. We need to be able to build trust, establish trust with individuals who've experienced trauma, and avoid re-traumatization. So making sure that our practices, by constantly re-asking what has happened in a person's life, and also not being sensitive to their experiences and avoiding intrusive questioning, is all part of adapting trauma-informed practices. Improve multi-agency collaboration. This is something else that you can do. Share information. Agencies need to share information more effectively. So we know that people are good at sharing information, but it's often from one agency to another rather than it being multi-agency. And once you've shared it, your journey doesn't end there with that person. It's about collaboration. And also sharing relevant history. There were a lot of people in Maria's working with Maria that didn't understand all of her history and her trauma. Joint planning. Develop multi-agency plans that involved all relevant services and ensure plans are followed up and reviewed regularly. And you can do that through the multi-agency risk panels. And consider a holistic approach. So consider all aspects of the individual's life, their physical health, their mental health, their housing, their social support in a coordinated way. You won't do it on your own. Enhance your safeguarding practice. So recognise self-neglect. Improve the recognition and response to self-neglect, especially in individuals with substance misuse issues. You know, talk about it amongst your team. Think about the cases you've got at the moment and where you think you might need to work more collaboratively. Use legal powers. People are reluctant to use legal advice powers or seek legal advice, such as on the Mental Capacity Act. And I think it's important to remember that we're not just talking about local authority legal advice. Most organisations do have their own legal advisors, and it may be that you need to take legal advice within your own agency and not rely just on the local authority legal teams. And also, are you involved in MARACs? How can you make sure that the MARAC meeting you attend is effective? Is the right information being shared? Are there agencies missing? How can you make the MARAC more effective? Oh, sorry, gone too far. Address housing issues. So working towards providing suitable and safe accommodation. I know that's a challenge, but, you know, we need to think outside of the box, and, you know, not all accommodation is suitable for everybody. So sometimes, and particularly in the case of the Maria, I think there could have been a consideration of specialist care home provisions because she needed care and support in a safe environment, which is what she didn't get. Support tenancy sustainment, so providing robust support to help individuals maintain their tenancies and address any issues. So Maria was very concerned that she was going to lose her tenancy, and therefore her and the team around her didn't give up her tenancy because at an early enough point so that she could be considered for further accommodation. And I think there are some difficulties there with legislation and understanding of legislation in terms of, are you homeless or not? And do you get different rights if you're homeless? Actually, probably not. But people believe that if they give up their tenancy, that they will not be offered further accommodation. And that is not necessarily the case. Improve communication and engagement. Innovative contact methods. People who have complex, difficult lives don't always keep the same mobile phone number for years and years and years. I don't know how long I've had mine, but I certainly have had it for many, many years. But people that live complex, difficult lives, they don't have the same mobile phone number. They often don't have the ability to charge it, or they lose their chargers. So we need to think about who is in touch with that person, and use, when we talk about collaborative multi-agency engagement, there are some people who are using outreach services who were seeing Maria regularly. They could have been the best communicators for different appointments that Maria might have had. And persistent engagement. We have to be persistent and flexible, and not just closing cases when people aren't engaging. And I think most organisations and most boards are trying to develop tips and ideas for how to keep people engaged, and how you can offer flexible services to encourage people to be able to trust the services, and that we are not seen as turning our back on someone without a thorough risk assessment and relevant information sharing with other agencies who are obviously may be seeing the person. Training and awareness. Professional development is really important, and we should be able to ensure that all professionals receive that training on trauma-informed care, safeguarding, and the use of legal powers. And also this really difficult topic of executive dysfunction, and increasing awareness of executive dysfunction and its impact on decision making. And that includes understanding how it affects the individual's ability to engage with services and make safe decisions. So if someone hasn't got the ability to understand what's happening around them, they may appear to have mental capacity, but actually their actions would suggest otherwise. And even though many professionals knew that Maria had an awful memory. I mean, that's what she said to people. Oh, I can't remember anything. My memory is really bad. So she knew she had a bad memory, but that didn't trigger people to think, well, does it go deeper than that? Has she got a cognitive impairment? And when you read in depth the alcohol section in the report, you'll see that actually it is research and evidence-based that people who have high levels of drinking are very likely to have brain damage, or certainly some amount of executive dysfunction, even if it hasn't gone as far as alcohol-related dementia. And that's all from me. Have I got 5 minutes then to show that video, Keith, or shall I leave
Karen,
it there?
please do. Please do.
Hopefully it will work. I have to go onto the internet to do it. So now I've gone back too many slides. So that's it. So let me Oh, I'm sorry, I've got difficulties with that. It's for some reason not finding the article, but it did yesterday, so I don't know why it's not there now. So I'm not going to take people's time in order to do that. So I'll come back to
the wonders of technology, Karen. Works
I
sometimes
know.
and doesn't another time. So thank you anyway. And thank you ever so much for your presentation, for your thoughtfulness and the clarity of what's gone on there. That's really, really helpful. If we can get that video back up again later, perhaps we'll be able to see it at the end. In the meantime, what we're going to do is, rather than take any questions, we're going to get through the next presentation from Imogen and then take any comments or questions via the chat box system later on. So Karen, for the moment, thank you. And we'll hear from you again with any questions or comments. And I'd like to introduce Imogen.
Hi, thank you.
Hello, Imogen.
Hello.
Thank you for joining us, and over to you, and thank you very much, and very much looking forward to this.
Fantastic. Thank you so much. Yes, so I'm here to present some of the kind of key learning points from another Safeguarding Adults review, which was published in February. And this was a Safeguarding Adults review of Maureen. And I'm going to start off just by giving you a little bit of background information about Maureen, telling you who she was and a little bit about her the case. So Maureen was a 66-year-old woman. She came from a Black Caribbean ethnic background, and she'd been living alone in a flat which had been owned by Lewisham Homes, the council's Almo, now part of the council, since 2011. And Maureen had experienced multiple losses in the past decade, and she'd really withdrawn from her friends. When I spoke to her goddaughter and her friend since childhood, they were really clear that Maureen had been a very intelligent, resourceful woman. Certainly in her younger years, she'd cared for her parents, for her brother, who had very sadly been found dead in his flat, I think from a heart attack, and a number of other family members. And perhaps, as a result of some of those losses, she'd withdrawn and had taken in over probably the last decade of her life to feeding pigeons. She'd had some court orders resulting from feeding pigeons. She'd even spent a brief period of time in custody as a result of, this is before the period of the Safeguarding Adult Review, as a result of breaching conditions not to feed birds. And as a result of some of the time that she'd spent in the criminal justice system, there'd been a couple of assessments of Maureen, both of which had kind of reached the conclusion that there was a degree of autistic spectrum disorder, an element of learning disability and low IQ, which is interesting. It kind of conflicts there, I guess, with Maureen's friends' perceptions of her as someone who, managed her money really well, and was, as I've said, a really resourceful person. Towards the end of her life, though, the property that she was living in was in a really, really, really poor condition. It was described by her family friend as being really squalid. She had been, as I mentioned earlier, feeding birds outside of the property, but she'd also been inviting birds, but if that's what you're doing, encouraging birds to come back to her flat. And that had led to the property being in a really, really poor condition. There were infestations of cockroaches to a very, very high degree. Visiting professionals described cockroaches sort of falling out of the front door frame on the doorstep. There was a lot of bird feces in the property, a lot of litter, a fair degree of clutter. And the property lacked basic facilities. Windows were broken. She often left the front door wide open. She didn't have any electricity on. And sort of in the last 6 months of her life, there were various kind of points at which there were concerns about her being confused, experiencing hallucinations. People noticed a significant amount of weight loss, obviously all part of a pattern of self-neglect. And Maureen was found deceased in her flat by the police, who'd been called out by adult social care because Maureen had been kind of missing for a couple of weeks. And that was in July 2023. And it was evident that she had been dead for some time. Interestingly, the coroner's reports just kind of come out in the last few weeks, and the coroner identified alcohol as an issue for Maureen, but actually that hadn't been recorded by any of the agencies involved in the period which I was asked to review, which has left us all kind of wondering really whether it's that nobody had asked or understood that or quite what that's about. But really interesting, and I guess it kind of reminds us all that there was a lot that we didn't know about Maureen. So just to kind of give you a very quick flavour, as Karen did, around what we did. It was a slightly lighter touch, well, it was a somewhat more lighter touch review than the one for Maria, just because I guess there was kind of less direct involvement with Maureen for reasons that we'll come on to. But I was asked to look at the last year of Maureen's life from July to July 2022 to 23, and there were known person inquiries requested from 7 agencies. And of those, it was decided that we would request IMRs, reports from the GP, Adult Social Care, Housing and the Mental Health Trust, who actually had quite limited contact, very limited contact actually with Maureen in the last year, but had some contact with her in the past, so that was felt to be relevant. And we held a learning and reflection session. This was actually held online. All of the people that had been involved in authoring those reports back in October of last year. And as I mentioned, I was able to get hold of Maureen's friend and her goddaughter by phone. And the really striking thing there was that when I actually made contact with them, sort of in autumn of last year, it turned out that they weren't aware that she'd actually died. They'd had some contact with Adult Social Care at the last month or so of Maureen's life, and they had actually been going back and forth, continuing to search for Maureen, but the news hadn't reached her that Maureen had passed away. And they were obviously really upset about that because, for all sorts of reasons, but not least because they weren't able to be involved in the funeral arrangements, which they would have liked to have been involved in and were even willing to organise themselves. So that, felt like a really, a moment that I'll come back to. And we've obviously tried to, I know Lewisham has tried to make amends around that and think a bit about its policies in relation to that, but obviously really upsetting for them. However, they were involved in the review, and I had a couple of follow-up calls with them both. And of course, I've been looking at supplementary evidence, not least the SAR for Maria, and a number of other kind of pieces of national research and guidance. So I was given quite a few key lines of inquiry. I'm not going to speak in detail about each of these. I'm just going to sort of pick out some of the chunkier ones, I think, for the purposes of today. But there is a section in the report which kind of addresses each of these issues, which I was asked to look at. But I'm going to focus mostly on mental capacity, safeguarding, self-neglect, really today, because I think those were some of the kind of key areas for learning and development. So, I mean, I guess the first thing to say is that this was an incredibly difficult case in terms of engagement. And I think it's a really important point that Karen made, that it's about the lack of the challenges with engagement rest within the organisations, not within the individual. And Maureen was, I guess some of the challenges here, and I've tried to sort of capture that with my open and shut door, is that although there were various attempts to make home visits to Maureen in the last few months of her life, often the door was either left wide open and Maureen wasn't in the house, in the flat, or the door was firmly shut. So there were actually only really a couple of occasions when a care coordinator from the GP surgery and a social worker managed to sort of have a conversation with Maureen in the doorway. I think when the social worker had the conversation, Maureen was saying that she wasn't fully dressed, and the conversation was sort of had round the other side of a closed door. So there were really only a few successful attempts to speak to Maureen, and the police had some other visits where they had been to the property and had spoken to Maureen on a few occasions. She was taken by an ambulance to hospital at one point. So there were agencies that had a glimpse into Maureen's life and spoke to her, but there certainly wasn't the kind of building up of that there wasn't necessarily that relationship in place that Karen's described in her Safeguarding Adults review. Though I have to say that the couple of the housing staff that came along to the learning and reflection session, it was really clear that there were workers from Lewisham Homes who had really got to know Maureen quite well over the years, but certainly in this last year of her life, there was a sense that if we can just build a better relationship with Maureen, we can engage with her, we can persuade her to take on to accept help. And unfortunately, the risks became too high and Maureen passed away before that ever really was able to succeed during this period. There was a coordinated approach by Adult Social Care and Housing in the last few months. There was a lot of communication between the two agencies, which was really positive. But it feels as though it would have required much more of an assertive outreach in order to engage Maureen. There were some good ideas floating around. Lewisham Homes shared with the social worker that had been asked to act as lead worker in the case, shared with them some photos of the places, of Maureen, and some information about the different locations that Maureen tended to go out and feed pigeons in. We know that the adult social care worker had spoken when she'd had a couple of unsuccessful visits to the flats. She'd spoken to the estate caretaker who obviously knew Maureen and was able to give bits of information about her whereabouts. But it felt as though there wasn't really the kind of, I'm assuming, the resource really that would have been required for somebody to really follow up, to get out to some of those locations where Maureen tended to go and feed the birds, and to really sort of join all of that up. The approach was one of go and visit, find Maureen wasn't there, try again in a couple of weeks. And meanwhile, the safeguarding risks were growing really quickly. The refusals of care and support were taken at face value. Maureen always said she was fine. She kind of tended to sort of minimise the issues that were there in the flat. She sort of said that the flat kind of just needed a bit of a tidy up. And I guess it sort of feels as though it feels from the records that there was perhaps a lack of professional curiosity around what was going on for Maureen. I fully understand how difficult it is when you've got someone who never picks up the phone, is hardly ever there, and you've got lots and lots of other cases. Really, really difficult, of course. But I just felt as though actually more kind of reflection on what the function of Maureen's behaviours were for her. And as part of that, I kind of felt like there was just a lack of psychologically informed support for those frontline workers. Quite a complex set of issues potentially for Maureen, and quite difficult to pin down exactly what her diagnosis was, and it wasn't exactly what the implications of that were. But from the level of detail in the IMRs, it just felt as though that element of real kind of input wasn't there as much as it should have been. And since Maureen's death, Lewisham Safeguarding Adults Board has produced this guidance on improving our approach to adult and family engagement. Some of the themes in that come out, things that we've touched on already, both myself and Karen, about taking a trauma-informed approach. We don't know much about the sort of the detail of trauma in Maureen's past life, but as I mentioned at the start, her goddaughter and friend told me about a series of bereavements and losses. We can only start to imagine about perhaps experiences of discrimination over a lifetime that Maureen might have experienced, and how that might have fed into her lack of trust perhaps for agencies. And certainly that kind of sense that for Maureen, the pigeons, I think, were her friends, from what I have read and what I've heard, and she obviously got a lot of comfort from those pigeons. And I wonder, it's easy, I know, to sit and reflect from the sidelines, but I wonder whether sort of, recognising the value of the pigeons and the birds to Maureen, and starting to use concerns about the well-being of those pigeons might have been a way in to think about engagement, even if Maureen didn't want to accept that she herself needed support. The guidance talks about using different methods and different locations, which, you know, as I mentioned before, there were sort of attempts at home visits for sure. There was some sort of creative thinking around different methods, but it just felt as though nobody really quite had the resource and the impetus and the permission to kind of really use all of that to maximum impact. There's talk in the guidance about what and how you record. I would say most of the recording, you know, felt kind of really quite neutral. There were some comments about, you know, in an early part of this period that we were reviewing around Maureen's case being closed because she'd been a non-engager in the past, and around a sense that actually, you know, probably her house wouldn't be suitable for carers to go into. I think there was certainly elements of that kind of thinking going on, and it's really important that we're really careful about how we record non-engagement, especially given that at the time people were trying to call on a phone which the GP's surgery knew had been out of order or not being answered for some time. So sort of at what point do we decide that somebody is not engaging? Is it just because they don't answer our call, or is it because they tell us I'm fine, or is it because they make a really informed decision that they actually don't want, but whilst understanding the support that we're really offering? So I'm going to come on to the other points about capacity and safeguarding and autism in a moment. So Maureen's case, I think, was a clear one of self-neglect. There were really high risks to Maureen and importantly, high risks to her neighbours in relation to some of the environmental health hazards coming from Maureen's flat. However, the case did not progress to a Section 42 inquiry. And I think the contributing factors for that were that there was a sense from adult social care, and this, sense from adult social care, and this was one of the reflections of the manager from adult social care writing the IMR, that this was quite a typical self-neglect case. There was an assumption that Maureen has mental capacity, you know, a keenness to kind of, you know, make the point that people have a right to make unwise decisions and that we need to respect people's autonomy. And I'll say a bit more about that in a moment. I've talked about the difficulties engaging and obtaining consent from Maureen to either refer her through or to adult safeguarding, or to, you know, take up the offer of care and support. And there were in that, I think, really low levels of awareness of the self-neglect policy, which I'm going to talk about in a moment. And also the kind of the sense that Maureen, I suppose Maureen sat on the cusp of a number of different possible specialisms. You know, there were, as I've mentioned before, there had been a diagnosis of autism. There had been in the past mental health involvement from SLAM. And the fact that when the case was raised with the MASH, with the multi-agency safeguarding hub, there was a sense that probably Maureen needed a mental health assessment. That meant that there was an additional step where Maureen needed to be referred back via the GP in for assessment via SLAM. And I think that just kind of created, I mean, that's the correct procedure, it was at the time, but A, it wasn't clear that that was actioned, and B, it just kind of created yet another kind of delay, another step that, when Maureen was so hard to engage, was really difficult. So yeah, the self-neglect and safeguarding policy. So this was clearly in place at the time of this case. So it has been updated more recently, and there seemed to be limited awareness of the guidance at the time of the SAR. One of the SAR authors said it would be a good idea if we had some self-neglect guidance. So it's clear that you know, that this hasn't, despite the efforts I know of the Safeguarding Adults Board, hasn't kind of consistently reached operational teams. And the policy says that if there are problems with self-neglect and hoarding and they escalate or reach a point that an adult with care and support needs is at risk or experiencing harm and is unable to protect themselves from this, then this should be referred to the local authority as a safeguarding concern, and that the local authority should then look to exhaust the full range of multi-agency powers and duties that they can to help coordinate through the safeguarding inquiry process. And I just pulled out from this is the high level risk factors which we should be looking for in cases. And it's at the point at which moderate risks are in place where we should be referring through and expecting a Section 42 inquiry to be kicked off. So in Maureen's case, I've just highlighted some of the things which I think constitute this being a high risk case. And meaning that really, this should have escalated through to an inquiry. So services, I mentioned the electricity wasn't on, not functioning properly. Someone had gone into the bathroom at one point and found that the facilities just weren't really usable. There were clear evidence that Maureen was at risk from weight loss and infection and a range of other cognitive mental health issues, issues around there not being a safe cooking environment. There'd been some discussion about environmental health, who decided not to pursue the case given Maureen's vulnerabilities. There were pigeons flying around in the property, and as I've mentioned, very heavy insect infestation. And Maureen's, the visible deterioration in her health, the isolation from family and friends, and her refusals that she needed help when the police or other professionals offered it to her. So all of that means that we, should have seen Maureen through to a safeguarding inquiry. And I guess what sort of struck me was that a lot of the frustrations that some of the professionals were reporting at the time could potentially have been maybe not resolved, because this is a complex case, but could potentially have been improved through that statutory process. So health was concerned that there wasn't a real sort of framework for following up and, following up on the actions that were agreed at multidisciplinary meetings. Towards the end of Maureen's life, housing and social care were frustrated that health weren't really involved. Nobody seemed to have any kind of input from psychologists or psychiatrists. So it feels as though actually with that framework in place, and there were concerns about whether, what information should be shared with whom at different points. And actually with the safeguarding plan in place, hopefully real sort of, those different multi-agency perspectives could have been levered in, and that governance could have been created, which was so sorely missed by the professionals who were sort of trying to do their best in Maureen's case, undoubtedly. So just a couple of points to kind of mention, really. Nationally, we know that in 60% of SAR cases, this came out of the National Analysis of Safeguarding Adults reviews published last year, 60% of SAR cases involve self-neglect, yet only 6 to 8% of operational safeguarding inquiries are for that subject. So there are few inquiries coming through, yet really sadly, a lot of deaths in this area. I guess some of the good news to report is that Lewisham has, since Maureen's death, taken a number of steps. They've set up a high-risk panel, to which self-neglect cases should be referred once the Section 42 safeguarding process have been exhausted. And in order to make sure that those self-neglect cases are being progressed to Section 42s, there's been put in place some additional monitoring by operational managers of safeguarding concerns and open cases around self-neglect, just checking whether those should have progressed through to inquiries, or indeed whether they should have be now progressing through to that high-risk panel. And you can see there the numbers suggest that we've seen more than 3 times as many safeguarding concerns for self-neglect progressing through to Section 42 as in the previous year. So that feels really positive, and I would suggest that continues. On the question of mental capacity assessments, so there was no mention of mental capacity or executive function in the chronology, despite the fact that Maureen had those assessments by clinical psychologists in the past, which and their kind of consensus around a degree of diagnosis does seem to established that first step in the two-step test for mental capacity. There seemed to be some element of cognitive impairment there for Maureen. And as I mentioned before, there was real clarity that that there shouldn't be an assumption that just because Maureen had made unwise decisions around pigeons, that meant that she didn't have mental capacity in across different areas of her life. But it feels as though, in kind of being really keen to uphold those principles of autonomy and protecting Maureen's right to sort of privacy, that actually that got in the way of the safeguarding response here. Now, clearly the engagement's really challenging, and there was a sense, I guess, from everybody that, it was probably somebody else's responsibility to do a mental capacity assessment, yet those other professionals didn't get much of a way into Maureen's front door either. And it feels as though there might have been capacity to take more of what I would describe as a 3D capacity assessment. And I'll share about a slide on that in a moment. But I also wanted to mention again, and I know Karen's already brought it up, this point about executive function, because it does again feel significant in Maureen's case. And I just took this quote from Lancashire SAB's grab sheet on executive function. So fundamentally, in unwise decision making, the person's fully aware, but's consciously disregarding or giving less weight to certain facts relevant to their decision. But in an executive impairment, the person cannot access and integrate the correct pieces of information and use them in a meaningful way to make the decision. It feels, again, as Karen said, that, more kind of legal advice, more advice and input from clinical psychologists or psychiatrists in Maureen's case, just to really understand what might have been going on here and what the implications of Maureen's diagnosis might have been for her decision making, could have been really helpful. I also just think at a really kind of fundamental level, I'm not entirely sure that Maureen understood what kinds of care and support might be on offer to her, actually. It's easy to assume that people understand what a Care Act assessment is, or that they understand what help might look like. But I'm not entirely sure that Maureen did fully understand that. And that's obviously a really key part of making the decision as to whether or not you want to accept help. So just to say a few words about 3D capacity assessments. This came from Neil Allen, a presentation that he did, and I've put the link in there to that. It just feels as though in Maureen's case, although nobody really had that opportunity to sit down and do what you might describe as a detailed assessment with her, various people were having contact with her. There were conversations, albeit quite sparse at different points over this period. And there was the opportunity to have conversations with people who knew her. And there were also bits of real world evidence. There were estate managers, neighbours, shopkeepers who all kind of saw bits of Maureen. She had turned up for a flu vaccine at one point in that last 12-month period. And it feels as though, having probing beneath that mismatch between Maureen, saying that all was needed was a little bit of a tidy up in the flat, and actually the conditions in which she was living towards the end of her life, and really understanding what was going on for her in that kind of conflict between what she was saying and the kind of real world evidence around her. It feels as though there was perhaps a way in which we might have looked more collectively in a multi-agency and longitudinal way at piecing that together. And that could have then given us the confidence to at least explore the option of whether a more directive approach needed to be taken. That was certainly what Maureen's friend and goddaughter felt was needed. They felt that actually at this stage, trying to sort of build a trusting relationship with Maureen through these little fragmented bits of engagement in the absence of real resource to do that kind of assertive outreach just wasn't going to work at this point, and that potentially going down a safeguarding route, using those relationships with the goddaughter to perhaps persuade Maureen to consider some sort of supported housing option might have been the only way to pull Maureen out of the situation that she was in. So just to kind of quickly just kind of summarise the recommendations made from the SAR, ongoing awareness promoting of those three, of the self-neglect policy and the engagement policy, which I've shared with you, and also that interagency escalation policy, which Karen mentioned. it was clear that health and housing felt as though, this should have been taken further. There was perhaps a lack of understanding around what the processes legally might have been for that and quite how to make that happen. So I think with greater confidence from other agencies to push for cases to be reviewed and reconsidered, that might have helped. Raising awareness, I've touched on the benefits of safeguarding inquiry and planning. So, there are lots of things, lots of processes we know we need to do, but actually if there's a real driver from a professional point of view for understanding what the benefits of taking this case to that next level might have been, obviously for Maureen, but also for the professionals really trying to kind of connect this up, it feels as though there might be more likelihood of people going down that route. I've touched on the way in which the use of the safeguarding pathway and high risk panel is now happening in operational teams. I advise that to continue happening with ongoing performance management. We really need to be questioning each other, challenging, reflecting, is this at the stage now? Should this be taken to that next level? Consistent use of the hoarding assessment tool. It was really obvious from the IMRs that various risks were being flagged at different points by different agencies, but because not everybody was referring those to that tool, it was quite difficult to kind of get a handle really on just how much clutter there was in the property, and for people to have used that consistently and perhaps populated that from all those different little bits of insight that people had, that could have really helped everybody to take, again, a really good 360-degree look at those risks. I'm conscious that there's been an all ages autism strategy and that there is now an autism hub that's commissioned within Lewisham. And I suppose just, it was unlikely that Maureen was going to connect directly with that hub, but it feels as though there could have been important second tier support really for those workers around thinking about the impact of Maureen's diagnosis and really thinking about what that might mean for practice. It wasn't clear that there was a consistent framework for ongoing risk monitoring. And, that again, a bit like the hoarding assessment tool, if everybody's clear about what we need to monitor and we're all feeding insights into that, it can make it much easier to realise really at which point we need to be triggering the next step of the process. And I've touched on this point. I know it's a resource issue, but actually, if we are going to engage successfully with people like Maureen, we do need investment, whether that's time within social work caseloads or whether it's another commissioned housing support type service that can get out there and go to the places where Maureen was visiting. We know on a regular basis she went to the DWP to sort out benefits. She was out feeding pigeons. She was collecting bread to take to the pigeons from a local shop. But, having that resource to really look at those areas and go out and meet Maureen there. I've touched on the multidisciplinary approach to gathering and recording a 3D mental capacity assessment. And we've talked a bit about executive function and, really sort of skilling up staff to understand what that might look like and what it might mean. And again, it was hard to tell from the detail on the IMRs, and unfortunately the social worker who was the lead social worker at the time wasn't able to participate in the reflection session. But I got the sense that there's a lack of confidence, skills, and certainly clinical supervision around using psychologically informed approaches to really engaging people who self-neglect. There's some great resources out there. Michael Preston Shoots done various webinars on self-neglect, and it's really clear that we need to think about self-neglect through an attachment lens, that we might be able to draw elements of motivational interviewing practice. I touched on using the pigeons and the relationship with the pigeons as a bit of a hook, perhaps, to sort of literally get through the front door with Maureen, and to really again think about how trauma might have affected Maureen's behaviours and the way in which she reacted to people in authority. And finally, as I mentioned, some real clarity there to make sure that in future cases, Maureen's friends of family who, Maureen's friends recognised they weren't next of kin, but to really think about how we make sure that news of a loved one's death is shared with people. Thank you very much. That's the end of my presentation. Stop sharing there. Thanks.
Imogen, thank you ever so much. There are a number of questions coming in. Wow, there's a big one here just arrived at the very end there. That 7 comments.
That's an essay.
An essay. Well done. We'll get through them, Imogen and Karen. Martin, are you going to help me with some of the questions that have been raised, or shall I just scroll through a few of them myself? One that I did pick up, Karen and Imogen, while Martin's getting to help me on that, a comment about whether you, as reviewers, you felt it would have helped the outcome of the cases if mental health social workers were part of ASC for undertaking safeguarding duties rather than being a part of SLAM, the local hospital. Any thoughts or comments on that?
While Imogen was talking, I was looking at the questions. So I have jotted something down there, and I think I've done reviews where both have been in place, and I actually worked in an adult mental health trust when there was the movement out from the Section 75 arrangement and the movement into separate organisations. But I think it's not about the organisation you work for or the, whether you sit in the same office or share the same space. It's about collaboration. It's about, and I think it's easier with Microsoft Teams these days to be able to have those catch-ups, and you can more or less be a virtual team together even if you work for separate organizations. And MDTs, which are and huddles that are very common in mental health teams. There's no reason why the mental health social workers can't be part of that, and I would consider that best practice. So I don't see it about being working together. I see it about how you think differently about collaboration and working together, whether or not you're in the same organisation, because actually that's what we want for the whole multi-agency team around the person, not just the mental health social workers and mental health workers.
Thank you, Karen. Imogen?
Yeah, I mean, I'd agree. I think, structures can sometimes become reasons to not collaborate, can't they? And like you, Karen, I've been in authorities where, people where actually it's moved out and then it's moved back in again. And, for the period that it's with the teams with health, there's better relationships with health and things get a bit distant from the local authority, and then you go swing back the other way. So there's maybe no absolute right way of doing it. But I think the way in which it's it feels in this case that, that became another step. It became the MASH. We can't really look at this at the moment because it needs to go back round through health to the GP. And it wasn't really clear, how things fell apart a bit at that point. It was never really clear that the GP ever made that referral. I guess everybody feels a bit like, oh, that'll take a million years to get through. Maureen will never open the front door. So I think, we don't need to wait until structures change or assume that we can't collaborate effectively within the current structures. But I could definitely see that extra point of go round this other part of the process and try to come in at that door certainly didn't help matters in this case.
Thank you both. Just before I get Martin to come in with any of the other comments, I mentioned at the beginning, really helpful if anyone wants to make any comments or thoughts about how they might take any of the learning from today into their practice, how it might inform their practice, or indeed how it might indeed change their practice. There's nearly 200 of us here today on this webinar, so lots for you to think about and reflect on there. Martin, you've just seen your picture arrive. You'd like to make any questions or observations for the panel?
Yeah, just to say, Keith, I've collated the relevant questions and comments so that the post I've got there in the chat, it's 1 to 7. So you've just gone through number 7. So they are the other collated questions to go through.
Thank you, Martin. I didn't realise that. I thought it was a question of 7 questions, not you collating all 7.
I've just gone through the whole lot. So you've dealt with number 7. So if you want to go back to number 1, then you're
absolutely start. So let's do that. Okay. Let's go back to number 1, a very good place to start. And then Karen, hopefully, when we've got through to number 6, because we've done 7, we'll have time for the video. So I've got them up here. I definitely believe that Section 11 of the Care Act is often overlooked and as the weight is given all too much to mental capacity only, and risks are not weighed correctly. Thoughts or reflections on that? Where should we start?
I'll let Imogen go first this time.
Go on, Imogen first, and I'll back you both backwards and forwards.
Yeah, it's interesting. So, of course, Section 11 outlines what happens when an adult refuses to have an assessment of their needs and care, and says that the local authorities not required if the adult refuses that, but that they must carry out an assessment if the adult is experiencing or is at risk of abuse or neglect. I mean, in Maureen's case, Maureen didn't. I don't think Maureen explicitly refused a Care Act assessment. And the social worker was mandated to try and carry out that Care Act assessment. You know, the authority was in principle trying to do a Care Act assessment, you know, in those last few months. The problem was they couldn't get through the door. But, you know, clearly, so I think from Maureen's point of view, I'm not sure, you know, yeah, it wasn't so much. I think there was a point in the early part of the chronology where there was a sense, as I mentioned, that, you know, there was no point trying to do a Care Act assessment because Maureen had a history of non-engagement, and, you know, that her environment just wasn't one that was going to be safe or suitable for carers to come into. And I think I see quite a lot of that generally within adult social care. I think there's, you know, we often take a too narrow view of what a Care Act assessment might look like. We focus on eligibility, we focus on thinking these are the services that we've got, are they going to actually help this person, are they going to be accepted by this person, and that kind of shapes the way in which we make our decisions. So I think at that point in the process, you know, there should have been a sense of risk, but I think in those last few months, to be fair, the authority was sort of trying to engage in order to make that assessment. And, you know, really, I think what should have happened was the escalation via the Section 42 route at that point. But I think it's an important topic. Thanks for raising it. Karen, do you want to say more?
Yeah, just that in Maria's case, I think definitely it could have been used. It could have been helpful to really look at the risk. She was being abused by her partner. She was self-neglecting significantly. And I don't think the risk was really fully understood. So I think it could have been helpful to have that as at least something to look at what those needs might be and work on them, on her needs one by one, which is probably what she could deal with. And certainly her housing need was at the top of her list.
Great, thank you. The next question then, number 2, is in regard to Maureen, do we know the last time a housing officer or social worker visited and managed to gain access? I'm curious to know if the living conditions were identified in the early stages of her difficulties. Imogen.
I'm just trying to understand the question. Yeah, so I think the last time, I mean, there was within sort of a month. I'm just trying to remind myself of the exact date. But there was a joint home visit in mid-June in which adult social care, housing, and Maureen's goddaughter went together. That was the last time that anybody actually kind of got into Maureen's property. Now, Maureen wasn't at home, but they did go in and, you know, could see the horrendous condition in which the property was in, and that was confirmed to me by Maureen's goddaughter. But in terms of people becoming, so I think at that stage, yes, that was the last visit. But you know, but I guess what I'm also wondering about is sort of the question suggests, you know, at what point were people aware of that early on, really, in the process? And I think it's fair to say that Lewisham Homes had, you know, had been in and out of Maureen's home because they'd raised concerns at the start of this final year of Maureen's life about you know, issues with neighbours and infestations. So I think it's pretty well known, really, that the state of the property had been that way for some time. The extent to which it had worsened, again, was really difficult to tell because, as I mentioned, people weren't kind of recording what they could see in a consistent way. So it's very hard to judge whether it had got worse over that time. But yes, the housing officer, you know, had been in and seen that.
Thank you. So question number 3 is, or comment number 3, in regards to both cases, was independent advocacy considered by the professionals to promote engagement with care planning processes? Should we start with you, Karen? Do you know anything about that?
Yeah, so I think in Maria's case, and I know across SARS nationally, we're finding this issue of, you know, a limited use of advocacy. But I think in Maria's case, there were several things. So first of all, advocacy wasn't considered because everybody assumed, because Maria was so articulate and could put her case forward and certainly was very feisty, and her family agreed she could be very feisty. Lack of capacity wasn't considered, so therefore advocacy wasn't considered because it was felt that Maria could well advocate for herself. What I think would have been really helpful in this situation is to use her family to support her as advocates. She had, you know, up and down relationships with her family like she did with a lot of people, but you know, her family did want what was best for her. So using them to help her, because they could sometimes make her see and could talk to her in a way that professionals couldn't. And also, I think the other important thing about thinking about advocacy was that, you know, what we see is that it would have been another person that she would have had to build a relationship with. But I think there were lots of people working with her who could have advocated for her. So the difference between, you know, professional advocacy and paid for advocacy roles, and those that could be the voice of Maria and that did know Maria well. So yeah, it's whether you're using advocacy with a capital A or a little a. But I think there were complexities, but I do think we could have done something different.
Okay, thank you. Imogen?
Yeah, advocacy was mentioned in the notes at a professionals meeting that was held sort of in mid-June, so sort of about 4 or 5 weeks before Maureen was found dead. So it had been considered, but whether it was offered or not, I think probably not at that stage, because I don't think anybody really had contact with her after that. And I guess, yeah, I mean, I can absolutely see the value for Maureen of somebody who perhaps could try to build a relationship with her in a from a non-authority position. But I can also understand why trying to, as Karen said, actually sort of, you know, trying to kind of build a relationship with another individual at this point and really explain what their role might have been. I understand why practically that would have been really quite difficult at this point. And I wonder whether there's something there about, when I think about advocacy and I think about the sort of assertive outreach function that I mentioned earlier, I wonder whether there's something that sort of comes together there, really. And I know we've got kind of organisations like Cloud's End in Lewisham that work with people who hoard. I don't think that wasn't quite necessarily perhaps the right approach. In this case, I don't think necessarily going in through a hoarding, decluttering perspective might have been the right one. I feel like maybe going in from more of an animal perspective might have been a better way in with Maureen, from what I can tell from the notes. But it feels as though there was definitely, you know, having somebody in this role who could have really got out there and connected with Maureen, had quite different kinds of conversations, whoever that might be, could have made a real difference, I think.
Thank you. I mean, it's a universal thing, isn't it, that often advocacy can be a real advantage to all sorts of people who either don't have their voices heard or struggle to have their voices heard. So a big up for that. We'll just go through these next 2 or 3 little questions, and I think we'll show the film, Karen, and then that'll give us time to reflect on any more points or questions that have come up. So point number 4, there's a fair amount of clutter in the home. Clutter rating scale comes to mind, and we've shared that, and it's going to be available on the site, so thank you. From a fire safety perspective, unlikely the BSA 2022 was in force at the time, They'd be interested to know whether Maureen lived in an HRRB. I'm not sure I know what an HRRB is. Can you help
It's a
me?
high-rise residential building. Yeah.
Thank you. Obviously.
And, it's a really good question. I know she lives in, I knew she lived in a flat, but I don't think I ever knew which floor she was on, which is a really, just made me think, why did I not ask that? Or why did I not know that? But yeah, so I don't know, to be honest. I know there was some discussion because we did raise within the process whether a referral had been made to fire safety, because it's
Yeah.
the London Fire Service were one of those agencies that had been asked to produce a known inquiry, known person inquiry at the start of this, but there wasn't enough contact with them. I don't think they'd had any contact. They'd done something years and years ago. And so there was a bit of a question as to why a fire safety referral hadn't been made during this period, to which I think housing felt that actually just adding another sort of layer of visits and authority in the situation, given how delicate the sort of relationship building was, wouldn't have been such a good idea. But I don't know. I mean, in some ways, just like pigeons might have been a hook in for Maureen, fire safety could have been one as well, potentially, and the fire service, coming from a very different perspective with a very different mandate, a very different offer. It's much more tangible, windows are open here, there's issues with your building and, your neighbours are concerned about fires. I don't know, very really hard to speculate, but yes, and I'm not entirely sure actually on what yeah, just sort of thinking through the implications there of what the Building Safety Act difference would have made. Presumably, that would have made people. I don't know. Presumably that would have meant that the housing provider had more responsibility for making sure that happened. I'm assuming that would be the case.
Thank you. So next observation question: when resource and capacity is an issue and a wicked problem, which it often is, then I fear that guidance gets lost in the noise. Does anyone know of any examples elsewhere in the UK where assertive outreach teams exist outside of mental health services? Karen?
Yeah. Yes. Actually, there was a lot of assertive outreach happening with Maria in Lewisham. So we know that one of the housing teams was going out to see her regularly, and she had a good relationship with them. There was an outreach facility there. She was open to the health outreach service through from Guy's Hospital, which I know is not in the Lewisham area, but they are commissioned to provide health outreach to the homeless. So she was often seen where she was bedded down. Obviously, the social worker was going out to see her regularly where she was bedded down as well. I think what we see is that we think of assertive outreach as being, a certain type of service and commissioned to do that. But assertive outreach can come in all forms. And of course, the police community support officers are a type of assertive outreach. I would argue that the ambulance service, when they're called, they offer health as an assertive outreach service. They are there on the scene. They will treat people on scene, and if people refuse to go to hospital, they'll carry out treatments on scene where they are able. Substance misuse workers were working in a assertive outreach capacity as well. So not in terms of the mental health team assertive outreach type approach, but there was a lot of outreach going on with Maria, which is why I said at the beginning of the presentation we had a lot of good practice. The issue was particularly with the GP practice, who don't offer any sort of outreach service, and the reason that she was discharged from those MDT meetings is because she wouldn't go to the practice. But like I talked about, using communication and collaboration, we could have overcome that. So I think in terms of assertive outreach, maybe not, but a lot of teams work in an outreach way anyway. So, but it's about them all working together so that they're not offering silo pieces of outreach, that actually it's why we said about a health action plan and having, if you'd got that high risk panel action plan, that actually everybody's feeding into the same action plan and knows the same information, because outreach can work really well, but it's still got to be coordinated, because for the person in receipt of all those services, it's confusing. So yeah, I hope that answers the question. But
yeah, very helpful, Karen. Imogen, any final reflections on that before we watch the video?
Yeah, just to say that there was, I've just finished an evaluation of a multi-agency team based within Brighton and Hove Adult Social Care, which works with people with multiple compound needs and works in an assertive outreach way. And I was just reflecting as Karen was talking there that, you know, Maria would meet the criteria for that team, but Maureen definitely wouldn't, because, you know, that's focusing more, you know, I mean, we don't know really to what extent there was perhaps an alcohol issue there for Maureen, but certainly she would be unlikely, I guess, given the fact that she A, had a property, B, the alcohol issues were very well hidden, and C, perhaps didn't have the questions around her mental health and the extent of that, you know. So I think there's something there around you know, where people who have complexity sort of fit within our systems in a sense. You know, she wouldn't have been seen by an outreach, by a homelessness outreach team, yet she was spending a lot of time out on the streets kind of feeding pigeons. She had some of these issues, but in quite a hidden and different way. And yeah, I definitely agree with Karen around that point about really collaborating. You know, one agency maybe hasn't got the capacity to do lots of creative visits out, but actually if you get a really clear plan and you're each going to try something different and you really share what relationship building and what learning you gain from those visits, that can make all the difference.
Thank you. Karen, are we going to be able to share the video?
Well, let's see, shall we?
Why not?
I've managed to find the right link. I'm just trying to share my screen. Can you see that?
Yes, we can.
The problem will be whether you can hear it. So do let me know if you can't hear anything. You should hear music.
I'm not sure we are. No sound. Sorry, Karen.
Okay, sorry. So it's Martin has put it in the chat. So I would recommend you look at it. And the reason why I use this, let me just stop sharing that.
Just while you're talking, Karen, Martin, I just wonder if we might be able to share it from your end.
Yeah, I've got it ready. If you want me to show it, I'll be able to get it up with the sound, I think. Thank
you. You say you had something, Karen, then we'll let Martin load it up and go.
Yeah, the reason I want to share it is because when you're working with people with multiple complex problems, I think it's really hard for professionals, and I think professionals beat themselves up time and time again about what they're not able to do. And although this video is not about people, actually, I think the message within it is really important to take away with you. So let's see if we can play the video, and then I can talk to how it comes at the end.
Okay, thank you. Over to you, Martin. Working.
I talk a lot about complex socio-technical systems. Sometimes people ask me, well, why is that different than a wicked problem? We don't use the word wicked problem because it's been used too much and it has too many different meanings, and so that's why we've avoided that term. And kind of is the same thing. The term wicked problems was invented some time ago, and it refers to problems of the nature that, well, sometimes it's even hard to define the problem. And it's hard to define the solution. And when you work on a wicked problem like world peace, how do you even know when you've succeeded? Because you may succeed there's peace for 2 years and then it breaks out again. So was that a success or not? So wicked problems are these really difficult issues that are difficult to define, that are indeed complex systems, that are indeed complex socio-technical systems, difficult to define, difficult to know how to approach, difficult to even know whether you've been successful. And yeah, the ones I'm looking at are wicked, complex socio-technical problems. So, but don't give up hope, because we can never solve some of these major problems. But however, we can make things better. We can make improvement. And that's often all that we can do. But if we're continually making improvements and enhancements and making people's lives better across all of the world, I consider that a success. It means we're never finished, but I consider that a success. And that's what you have to do with wicked problems.
So
Thank you.
You could, yeah, I just like that, because I think it, you know, if you think about safeguarding adults instead of world peace or, you know, environmental problems, I think it's really important to remember that you don't know, that little thing you might do that makes a difference might actually be the start of recovery for somebody. So I just think that that's really important to take away with you.
Great, thank you. Well, it's just been so interesting and so informative, so many interesting things. And to say, there's so many people on the call. So hopefully the recording, well, it has worked, but hopefully people can use the recording in other learning events whenever they want to. I'm just desperately trying to look up any other questions or thoughts that have come in. And there seems to be one here. I think it's very hard whenever we get to a point where we're fundamentally trying to impose an intervention on a non-consenting adult, whether they have capacity or not. The court of protection process is hugely challenging, and that really is a major issue as to how do we try and impose an intervention on a non-consenting adult, and are they actually consenting, or do they have an executive function issue and therefore don't even have the capacity to really consent on the issue? I've just raised a few thoughts there. Karen, Imogen, any further comments on that, or is it just yes, it's a problem?
Yeah, I mean, I think, I'm also kind of looking out of the corner of my eye. There've been a couple of questions around Maureen's case and kind of legal interventions from a housing and environmental perspective. And it kind of feels like part of the same problem in a way. You know, there was just on a factual level, I mean, there was housing did sort of issue a notice seeking possession to take back the property. They tried to serve one of those back in April, and then I think they finally served one tragically at the point, you know, they knocked on the door and must have pushed it through the letter through the front doorstep when Maureen was presumably lying in the property deceased. And, you know, there were referrals to environmental health, having originally felt that actually she was too vulnerable to make those referrals. And I mentioned that partly because, you know, in response to the questions, but also in response to your point, Keith. It's incredibly difficult, isn't it? When we, on the one hand, you know, I'd be probably, you know, if someone had immediately tried to evict Maureen on the basis of this, I'd have probably been like, that's really counterproductive and traumatizing and really difficult decision to make, isn't it? Obviously, you're trying as a housing professional to balance the risks to the whole of that block and to the neighbours and all of those other things. But at what point do you come in heavy, so to speak, and try to sort of, you know, force a decision, force a move? And at what point, you know, do you kind of continue trying to engage and build trust and relationship with a person? And you know, despite the kind of reflections and the learning that I've shared today, I totally recognise what a huge dilemma that is. And I suppose I just wanted to end in Maureen's case by saying that, you know, despite the fact that her friend and goddaughter, you know, felt that really we needed to just kind of get in there, make her, you know, evict her, try and get her into somewhere that could have, you know, given her, you know, some sort of supported housing setting, perhaps, that might have helped her to really kind of start to look after herself a little better. They could also really see that the workers massively cared and wanted the right thing. And so, you know, I suppose I just wanted to end with that, you know, how we make those decisions in terms of, you know, how we use some of these legal powers and the complexity of using some of them is genuinely really challenging. But I would just in Maureen's case, say, let's use the kind of multi-agency structures and, the breadth of our knowledge around, how people respond psychologically, and the breadth of our knowledge about mental capacity and safeguarding, to really try and work in a much more collaborative, concerted, decisive way to make the best decisions in these cases.
Thank you. Just before I come to you, Karen, for any final thoughts, just a reminder, we'll probably finish a few minutes early. So if you've got any reflections, particularly about any learning you'll take away or how it might have an impact in your practice, please do stick them in the chat box function. That'd be really, really helpful. Karen, any final reflections or thoughts from yourself?
Yeah, just I think, looking at Maria's case, she's not on her own. There are lots of Marias in the world. I was just looking at somebody was just saying something about general advocacy services aren't available. They are in some areas of the country. So some commissioners do provide general advocacy. There was also, I've lost it now, sorry. So yeah, I think that we just need to work coordinated and collaboratively. So in a coordinated, collaborative way. And if we can do more of that, which is why I like learning event, not this learning event, but when we do learning and reflection workshops with professionals, actually we get them around the table and they all start talking to each other. And usually one of my comments is, this is how we need it to happen in practice. So, we are trying to emulate what we want, but no, I think we continue to learn, we continue to empathize with professionals who are trying their very best, and most absolutely are, in a difficult, tough, resource depleted world. So well done to everyone.
Thank you, Karen. Great points made there. I think the thing I'm reflecting on a bit in both of these cases is that increasing understanding that capacity is not yes or no or binary, and the whole executive function and the capacity for a decision specific event is really, really important for us to get our heads around and to increasingly understand. And in this case, obviously the influence on one of these cases, the influence of alcohol and potential drugs as well on that ability to make a capacity decision. Well, I'd like to say thank you to you both, and thank you for everyone for attending. You made a really good point there, Karen. It's these events where we can stop and reflect and think that are sometimes the most useful in a busy world where you're absolutely right. Most people are trying their hardest in very difficult circumstances with very often diminishing resources at our fingertips. So for all of you that are out there safeguarding people, thank you for all you do. And thank you for the way that you do it and the ways that you try. There was a question, a comment, when will the slides and the resources be on the website? I think they will either be on the website now or they'll be on the website very soon. Martin, I'm just pausing. Have I got that right?
Yeah, it'll take us a few days, Keith. We'll get the video edited and we'll put the slides up, but we'll email all of the delegates to let them know when that's going to be ready.
Thank you. So the presentations and the video won't be immediate, but it won't be long. It'll only be a few days. And Martin's rightly helpfully put a link there to a lot of other resources around safeguarding and capacity and DOLS, etc. So I just want to say thank you. Thank you to you all. Keep in, if you want, the next minute or two to stick any more thoughts or comments in the chat box. But I think otherwise, you've got a few minutes back of your life. And have a good, lovely rest of the day. Thank you both, Karen, Imogen, and